السلام عليكم ورحمة الله وبركاته. Okay, our colleagues, we'll start the second part of this session. Again, many thanks for Dr. Naha for this amazing session and great cases. I hope to follow her instructions because Dr. Naha already in the UK. She is in the system. Me outside the system, but I'm trying to help with my little knowledge and little skills. Okay, we will start now a group of cases, and according to time, we will continue. The first group of cases today about volume loss. If you see a case with a volume loss. The second group would be about reticular opacities seen in X-ray, in chest X-ray. Okay, we have a candidate with me, Dr. Ahmed.
Candidate 1, are you there? Okay, candidate 2? No, candidate 2. Okay, candidate 3?
Candidate one
Candidate,
want to be unmuted. Just unmute yourself.
okay,
Okay.
okay, 1 second.
Okay.
اوكي.
السلام عليكم. How are you يا boss?
الحمد لله تمام. ازي حضرتك؟
Oh, الحمد لله. Okay. The first case will be this one, but start with this one. Chest pain.
chest pain. Okay.
Yes.
I'm presented with the frontal radiograph of the chest of adult patient with the chest pain. Okay. I cannot see any obvious abnormality. So I am going through my review area. Okay. Both apex are remarkable. No evidence of
What you are looking in the lung apex? Looking for
any mass lesion
or
or pneumothorax.
I'm
Okay.
listening. Okay.
Okay. I can't see any. I think there is minimal left pneumothorax.
Yes, yes.
Yes, now I noticed it now. Yes, I see the line now.
Okay.
Okay.
This is just a welcoming case. Okay.
Okay.
It is not the first case. Okay. Remember, emergency and safety. One of the most important issues in the exam. You may perform very well in many cases and fail in the emergency cases. The whole set of cases will be lost. So take care. Emergency findings. Emergency findings. Before you tell the examiner, I cannot see anything. Please check for pneumothorax, pneumomediastinum, pneumoperitoneum, and in children for rib fractures. Okay, this is just the start. It's okay. No, just normal age. Okay. Our case, yeah, boss, now shortness of breath.
Okay. I'm presented with the frontal chest radiograph of a skeletally mature patient. There is a veiling of the left hemithorax, the upper part of left hemithorax, with the I think there is a mass lesion at the hilum. The left there is reduced volume of the left hemithorax and elevation of the hilum and elevation of the diaphragm. Okay, I'm checking the bones. The bones are unremarkable. No evidence of pleural effusion, no evidence of pneumothorax or pneumomediastinum. So this appearance of left upper lobe collapse likely due to hilar mass.
Actually, no extra density here, but this is the effect of uplifting of the hilar due to the upper lobe collapse. Okay.
Okay.
No
So
over density. If you compare the no extra density from X-ray, you have to see obvious mass. To say
okay.
it is a mass, you see obvious mass. But in such case, just uplifting. Okay, continue, boss.
Okay, so the cause it may be due to a carcinoid or hilar or mediastinal mass with secondary compression of the bronchus or other bronchial mass. So I will urgently refer the case for CT post contrast of the chest to detect the cause. Okay, CT post contrast of the same patient. There is it confirms the presence of left upper lobe collapse.
Okay.
And okay, I'm now trying to look at the cause. I will see the bronchus. There is endobronchial lesion, hypoenhancing mass lesion seen.
If hyper enhancing, what is the
If
diagnosis?
it's hyper-enhancing, it will be carcinoid.
Okay, so what's the next step if suspected carcinoid?
Ectoretoid scan.
Okay. If I'm thinking this is a mucocele versus mass, what should I do?
Mucocele.
Just a
versus-
fluid versus obstructing mass. Both non-enhancing.
Yes. Okay, I think we should go for biopsy bronchoscopy.
Hounsfield unit first. Okay.
Okay.
Hounsfield more fluidy. Okay. Not soft
That is
tissue.
more common.
Okay. Common is common. And of course, you correlate with the age of the patient. So again, the main finding here is volume loss. Left hemithorax volume loss. What are other signs of volume loss in this case? Shift of the heart, shift of the trachea, uplifting of the hilum, uplifting of the hemi diaphragm. All these signs guide us toward left upper lobe collapse, plus one specific sign.
Left Seychelles sign.
Yes, left sickle sign. Before I go through all cases, I will review just rapidly the signs of volume loss. Volume loss mainly lobar collapse or other causes like fibrosis. In lobar collapse, let's take it one by one. Right upper lobe, maybe left upper lobe, maybe if in this area middle lobe or lower lobe. First, detect the signs of volume loss, like reduced the hemithorax volume, reduced left hemithorax volume. What else? Translucency of the lung. In collapsed the lobe, the other lobe will show compensatory hyperinflation, reduced pulmonary vasculature, as compared to the opposite side. What else? Look at the trachea, look at the heart, shift of the trachea, shift of the heart to the collapsed side. Remember the retrocardiac area. This is normal retrocardiac area. You have to see in between the ribs, okay, in most cases. But here, extra density, retrocardiac density. Think of lobar collapse. What else? Also the hilum. This vessel is called descending pulmonary or interloper pulmonary artery. Where is the left side absent? Because it's included in the collapsed loop. Also in this side, this is the interloper or descending pulmonary artery. Here I cannot see. It's included in the collapsed loop. So and also the diaphragm. So very important. Look for signs of volume loss. If you see any of these signs, guide the case toward lobar collapse and mention the causes according to age. in young age, it may be foreign body inhalation, also mucus plugging in asthmatics, middle age carcinoids, older age group. Okay, think of either primary bronchogenic or endobronchial metastasis. So this is a classic case of left upper lobe collapse with left sickle sign. Okay, boss. Candidate number 2. Thank you, Doctora.
Thank you.
Number 2. Number 3.
I think no.
Unmute two candidates successively. Yes.
Is candidate 3 or 2?
Okay, okay. Just enlist the finding here before you go to your case. What are the findings?
Yeah, so there is a veil-like opacity in the left upper zone. There is a linear lucency which is surrounding the aortic knuckle and the descending aorta.
Yes.
Left hemithorax volume is decreased.
Yes.
And there is little bit of crowding of the ribs, and the trachea is deviated towards the left side. And mediastinal shift is slightly towards the left side, and the diaphragm is elevated.
Very good, yeah, boss. So it's a classic case also of left upper lobe collapse, and here is the left sickle sign. Okay. Shortness of breath in post-operative period. The pre-operative radiograph was normal. Just the post-operative radiograph for spine shows this pattern. What happened here?
There is increased retrocardiac density.
Yes.
And left hemidiaphragm outline is lost, and left hemithorax volume is decreased.
Yes.
So there is probably left lower lobe collapse with some hyperexpansion of the left upper lobe.
Yes, in such case, of course, we may think in also mucus plugging or some denture swallowing in old age. Okay, no pneumodistant. No. Okay. Another case for you also, Yabus.
Yeah, there is a triangular retrocardiac opacity with loss of outline of the medial part of the diaphragm, and left hemithorax volume is decreased. This is another case of left lower lobe collapse.
And also, you see the highland here. I cannot see it. Yes.
Yeah.
Absence of, it's called finger sign. Absence of this finger sign, because the interlobar artery is already within this triangular retrocardiac opacity, which obscures the medial aspect of left hemidiaphragm, and just also mention the causes. Okay, the previous. It was normal X-ray before the operation. After operation, okay, retrocardiac opacity, elevation of hemidiaphragm, loss of lung volume, also some hilar retraction downwards. These are the classic pattern of left lower lobe collapse. Okay. Again, the same. Okay, I will mention and I will describe it. Reduced left hemithorax volume, retrocardiac opacity, may have slight triangular shape, loss of medial aspect of definition of medial aspect of hemidiaphragm, shift of the mediastinum and the heart to the same side, mild crowding of the lips. Okay, boss, the last case for you. Same candidate. Okay.
Yeah.
Cough and fever.
Yeah, in here also I can see that there is decreased left hemithorax volume, and there is increased retrocardiac density as well, but the diaphragm is clearly seen. And so I think this is lingular segment collapse with but
what
left
is the relation? What is the relation between the lingula and left cardiac border?
Yeah, left heart margin should be obscured.
Yes,
This is
yes.
that, yeah.
Very well
So
defined.
yeah, it is defined.
And also diaphragm looks in place. Okay,
Yes, so
you can ignore the little differences in volume. So what is your diagnosis? What's your suspicion about this?
so I'll think of a retrocardiac mass here
Cough, fever?
or consolidation, which
Yes,
is
yes, yes. Ill-defined margin of this retrocardiac opacity with no evident signs of volume loss. You have to correlate it with the patient complaint. Fever and cough, think of pneumonia. In which lobe? Most likely in the posterior segments of right lower lobe. So if there is retrocardiac opacity with loss of definition of hemidiaphragm and reduced significant reduction in the left lung volume, think of left lower lobe collapse. If no significant reduction in the left lung volume with preserved hemidiaphragm definition, but increased retrocardiac opacity with no defined border, think of consolidation. With well-defined border, what are the possibilities?
with ill-defined border.
With well-defined.
If it's well-defined, it could be collapse or it could be a mass lesion.
The collapse has triangular shape with volume loss, but here no volume loss. Other differential for mass, retrocardiac mass, what could be?
Metastasis or a primary mass lesion.
You can arrange it according to age. If young, if child, I may think in what?
Round
Yes,
pneumonia.
very good. Round pneumonia, pulmonary sequestration. If the patient has acute abdomen, think in hiatus hernia, for example, maybe obstructed. Okay. In old age, think in either metastasis or bronchogenic. It's okay. Good, Yabos. Very good, Yabos. Okay, the next candidate. Thank you, Yabos.
Thank you, sir.
Okay.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. What you see, Yabos?
I am presented with a frontal chest radiograph of skeletal immature patient. I can't demonstrate first I can demonstrate the left breast shadow clearly. I am concerned about left mastectomy.
No operations. Very good start. No operations. Okay.
Okay.
Yes. Here's the shadow. Okay.
Oh, okay. I can see that there is increased density of there is increased retrocardiac opacity. The density of retrocardiac opacity. I can't see the medial border of the left hemidiaphragm clearly. So I am concerned about the left lower lobe lesion.
Lesion?
Or collapse, but not clear, not triangular, not very triangular opacity. However,
Yes. Okay.
so it could be
Sometimes the opacity or consolidation, if resting on the diaphragm, it will cause silhouette sign. Okay.
Yes.
So you are thinking between consolidation and collapse.
Yeah.
How to differentiate between them?
I'm searching for the air bronchogram within.
Good.
Can see air bronchogram.
Subtle, maybe subtle. Okay. What else?
The lung volume, if it is collapse, there will be a loss of lung volume on the affected side, like a depression of the hilum. I can see depression of the hilum on the left side. There is no definite elevation of the left hemidiaphragm.
Good.
The mediastinum is mildly shift to the left side.
Yes.
So I am concerned about collapse. There is no hilar shadow or hilar masses.
Yes. In my opinion, this is a form of mixed It has
Next
some, yes, it has a consolidation pattern with mild volume loss. Consolidation collapse may occur together, but you have to correlate also with the clinical findings. Fever, cough, primarily consolidation with element of collapse. Okay, boss, after no, it's the same. What's abnormal here?
me also.
Yes, listen. Okay. Name a specific radiographic sign. The same case, but in lateral view, just for localization.
I can see that there is increased density in the lower يعني projecting over the lower vertebrae than the upper يعني
Yes,
reverse of the normal appearance
good.
that posterior lower loop collapse.
Okay. No one answer in the chat يا جماعة يا bosses. Okay. This is called loss of more black sign. More
Yes.
black sign. This is normal finding in chest X-ray. If you are going from up downwards, if you are going from up downwards, normally more lung tissue, more gases here. So gases overlying the vertebrae cause a reduction of the opacity or more translucency. But for example here, oh, it's opacity. It's the reverse of the normal. Loss of more black sign or dense spine sign, whatever, it suggests there is opacity overlying the vertebrae or in the posterior lung segment in the lower lobe. Other differential, of course, posterior mediastinal mass. Good, yeah, boss, still with me, please. The second one, oh, it's a child born with difficult delivery. I know it's chest cases, but just
no
tell me any emergency, okay?
I am presented with chest X-ray of a newborn. I can see that there is a heterogeneous opacity seen involving both lung fields more on the right side. Regarding the patient history of difficult labor, I am concerned about meconium aspiration. There is also no pleural effusion bilaterally. المفروض في الأول all lines يعني first the NG tube is seen in a good position.
Okay. These externals. Okay. Any emergency in this case? I know you are correct, by the way. It's meconium aspiration, and I'm not talking about its term. Okay, I'm not talking about the chest or lung volumes. Any emergency?
I'm searching for pneumothorax.
Yes, good.
My clinical practice, I will magnify the episodes more, but I can demonstrate different pneumothorax bilaterally.
Okay. What is the cause of more lucent left hemithorax volume? It's pneumothorax.
The patient is supine.
Yes. This is the appearance of pneumothorax in supine position. You may find deep sulcus sign or marked well definition of the cardiac border and the left hemidiaphragm as compared to the right side, because both lung field should display the same pattern. Here, shaggy border of the cardiac shadow and shaggy border also affecting the hemidiaphragm. Here should be the same, exactly, should be symmetric. Okay, but here it's very well defined. It's more lucent. This is one of the signs of pneumothorax in infants. No problem. I will repeat this with a pediatric session. Okay, I'm welcoming you. Okay, the last case for you also.
I am presented with frontal chest radiograph of a skeletally mature patient. First, I am talking about the lines and the tube. The tracheostomy tube is seen in good position. The nasogastric tube is seen also in good position. The central line is seen in the image is easy, but I can see that it reaching the atriocephal junction on the right side.
Yes, I will
there is
make it
surgical
zoom. Okay, good.
There is also surgical clips are seen on the left hypochondrium, could be related to previous operation related to the spleen or stomach. Regarding the chest or the lung, I can see that there is opacification seen involving the right lower lung zone.
Good.
There is no air bronchogram within. There is no definite volume loss.
Are you sure?
There is no definite. There is mild shift of the
Yes.
distal bronchi to the right side. There is mild rib crowding on the right compared to the left.
Good.
So I concerned now about collapse of on the right side, as there is the silhouetting of the right hemidiaphragm, and there is I am concerned about left middle and lower loop collapse. There is silhouetting also.
You mean right?
Right, yes.
Yes,
I see.
yes. Okay. Right only or right and middle?
There is no definite silhouetting, however, it projects to go over the right cardiac border.
As long as you see the right cardiac border, usually the middle loop is free.
Okay.
Okay. So this is considered a retrocardiac. Okay. And also projecting opacity, projecting over the right lung field also. It has a triangular shape. Okay.
Yeah.
So now what is your diagnosis?
Right lower loop collapse.
Yes, in addition to other findings that is present post-operative, most likely by mucus plugging. So this is a case of right lower loop collapse. As you said, reduced right lung volume, indistinct right hemidiaphragm. What is this? Maybe the transverse pressure shifted down. I still see the right cardiac border, means the middle loop is not collapsed. I cannot see the hilar vessels. The descending looper or interlooper artery is not seen on this side because it's involved within the collapsed loop, in addition to the ipsilateral mediastinal shift. Very good, yeah, boss. In case of cardiac, in case of effusion, usually we have a meniscus sign. The reverse of here. Okay, the border will be rising up to the axilla. Okay. Okay, I am answering how to differentiate pneumothorax and superficial. Okay, I have another case. It will answer your question, Yabos. Okay, I think maybe the last case. Okay, thank you, Yabos. Next candidate.
Yes, please.
Okay, shortness of breath.
Okay, this is a frontal chest radiograph of adult patient where I can see there is a triangular opacity at the right lower lung zone, specifically at the right retrocardiac region. There is a signs of volume loss of the right hemisthorax, tinting of the right hemidiaphragm, downwards placement of the right hilum. I cannot see the hilar pulmonary vessels clearly. Where there is also a mediastinal shift to the right side, as well as a tracheal shift to the right side. All those cases, all those signs are in keeping with an right lower lung collapse. With I'd like to. I'm checking the left lung for any evidence of any abnormalities. But it's clear. I'm checking also the ribs and the bony thoracic cage. no detected other bony abnormalities. I'd like to compare with the previous images if it's available and correlate with the clinical history of the patient. If he is an asthmatic patient, I will go with the mucus plugging, or post-operative circumstances. Also, mucus plugging is considered. If his another differential diagnosis include an endobronchial lesions like carcinoid or carcinoma, or maybe extrinsic compression upon the trachea from enlarged mass or lymph node, which is not grossly here.
Very good.
So I will urgently convey my findings to the referring physician and recommend further follow-up.
Very good, yeah, boss. Very good. It's a classic
Thank
case also of retrocardiac opacity to the right side, silhouetting the hemi-diaphragm and associated with variable signs of volume loss as you enlisted. In such cases, we correlate with the history. We assess the bones for any distracted bone or bony lesions, for any surgical clips, for mastectomy. Anything guide us toward an oncology case. In such case, if we see any of these finding, we may suggest it's endobronchial metastasis. Very good, yeah, boss. Okay, the second case for you too, cough fever.
Okay, this is a frontal chest radiograph of adult patient where I can see there is an opacity of the right lower lung zone. It's partially silhouetting the middle portion of the right hemidiaphragm, while the right cardiac border is clearly seen. Since there is an history of an fever and cough, so I will go with an infective etiology. I'm checking the left lung field. Clear
Okay.
lung field, no evidence of any other abnormalities.
Name
This is
it.
a lateral chest radiograph of the same patient. It shows a left a lower retrocardiac lower opacity with an loss of the normal more black sign. The
In
no
keeping
other
with.
abnormalities could be.
Okay, okay. The last case for you, mild fever.
Okay, this is a frontal chest radiograph of adult patient who presented with mild fever. I can see that there is indistinct right cardiac border with an indistinct, most likely to be an infective etiology like consolidation or collapse, or an other cause like pictus excavatum. However, I could not appreciate the seven-shaped ribs. So since the clinical presentation is fever, so I will go with an infective etiology like consolidation. Collapse also could be included within the differential diagnosis. However, there is no obvious signs of the right lung volume loss or tinting of the diaphragm or downward displacement of the hilum or mediastinal shift.
In middle lobe collapse, maybe no significant volume loss. So it mimics the consolidation. Fever and cough can differentiate. Okay. If no history, really, I will say it's collapse first. Okay. If history of fever and cough, then consolidation. What other mimicas? As you said. Thank you, yeah, boss. Thank you.
Thank you.
Okay. The next candidate.
Okay.
Welcome, yeah, boss.
I'm presented. So I am presented by frontal radiograph of the chest of an adult patient demonstrating opacity involving the right lower zone. I see the right hemidiaphragm clearly. I see the vessels of the right lower lung clearly. I think that this may be opacity in the chest wall more than the lung opacity. I would discuss this finding with the clinician. I will review the PACS system if we have any previous chest CT to further evaluate.
Okay. Can you comment on cardiac borders?
The cardiac border, the right cardiac border is indistinct.
Completely lost. Yes, yeah, boss, completely lost here. Okay. So it's a definitive middle lobe pathology. as our friend said before, maybe collapse or maybe consolidation. With this pattern, also the middle lobe may show some opacities. Okay, so as you said, correlate with history of fever and cough, unlikely chest wall. Okay. Next case for you, ya boss. Chronic chest symptoms, young age.
I'm presented by frontal radiograph of patient chronic chest symptoms, middle-aged patient demonstrating triangular radio-opacity in the right middle zone. There is reticulonodular shadowing, bilateral upper lobes more on the right side. I'm thinking of fibrotic process resulting in elevation of the right hemidiaphragm, so involving the right middle lobe and right upper lobe.
Yes.
I'm thinking of granulomatous infection such as TB. I will inform the referring physician for contact isolation and sputum culture, and I will.
Okay, negative for TB. Any other differential diagnosis?
If negative for TB, I will think of other fibrotic process. So upper zonal fibrotic process can be seen.
Also, can you see anything other than fibrosis?
There is cavitary.
Yes, and
cavitary nodules.
Or
and the
bronchiectasis.
bronchiectasis.
Yes. Okay. Also here, rounded, tram-like, and rounded. Okay. Can you change now your thinking?
Yes. So I'm thinking of cystic fibrosis as a possibility.
Yes.
And I will review the patient previous imaging to check if there is any evidence for.
Okay. What test done for cystic fibrosis?
A chloride sweat test.
Okay. Okay. تسلم يا boss. Thank you يا boss. It's middle lobe collapse, just elevated or shifted from its location. Okay. Trauma. For you يا boss.
Okay, so I'm presented by frontal radiograph of the chest of an adult patient presenting with trauma. The striking abnormality is shift of the mediastinum to the left side. Also there is widening of the left CP angle appear more prominent, or sorry, the right CP angle.
No symptoms. NB, no symptoms, just a trauma. But the patient has no complaint. Okay.
Okay, so I'm thinking that maybe there is deep sulcus sign on the right.
Usually associated with some pain. Okay.
Right.
Any abnormality here?
So there is indistinct border, right heart border with.
Yes, this is a clue. Indistinct right heart border. Then go. If the patient has no fever, no cough, you can ask for
chest or lateral. We can do lateral chest, and
because
this could
I
be
wanted to lateral. Okay. Yes, it's Victus. Okay. So the three pathologies which cause indistinct right cardiac border, plus or minus some haziness. This haziness may be just artifactual due to mediastinal vessels or hilar vessels. So it is not true haziness. Okay, like here in pectus excavatum or here in middle lobe consolidation. Of course, I want a history of fever and cough, or in cases of collapse. Okay, this is a case also of middle lobe consolidation, no shift, no collapse. The horizontal fissure have to be horizontal. Okay, not like this case, not shifted like this case. Excellent, yeah, boss. I think this is the third group. Okay, another welcoming for you. This is the last case, trauma.
So I'm presented by a frontal radiograph of the right shoulder demonstrating loculated opacity in the right chest wall, I'm thinking that there is hemothorax based on rib fractures and right pleural fluid. So this could be right hemothorax plus pneumothorax also. There
Where
is
is
actually,
huh?
yeah, so there is a pleural line.
Yes,
And
yes. You see this line,
yeah,
and here this area devoid of lung markings. This is pass or fail case. It's a common case in the exam, cervical spine or shoulder X-ray, and there is emergency in the chest. Mostly traumatic case, but sometimes you may find here a mass, incidental mass. Here is rib fracture with some hematoma, and here is pneumothorax. In practice, I saw this case many times in motor car accident, comment on the shoulder, there is pneumothorax here. So it's not just the exam case, it's a practical case. Thank you, ya boss. Well done, well done. As the next candidate,
Good evening, ya boss.
Alhamdulillah. How are you, ya boss?
I'm fine, thank you.
Okay, shortness of breath.
Yes, I have been presented with a frontal chest radiograph for an adult patient. The main abnormality, I can see that there is opacity seen occupying the right upper and medial lower lung zone. I cannot see any similar abnormality in the left lung. I can see that there is similar abnormality seen in the right lower lung zone.
Here may be related to breast shadow. It's okay.
Yes.
Okay.
So the main abnormality, I can see that there is opacity occupying the right upper and middle lung zone medially. There is no costophrenic angle obliteration, no cardiomegaly. I cannot appreciate any pleural line for pneumothorax or pneumomediastinum or pneumoperitoneum.
Okay.
I can see any obvious abnormality could be seen of the available bone images. I want to correlate with the patient history to see why this patient come to the hospital, and I want to see if there is
sudden onset of shortness of breath. What do you think?
sudden onset of shortness of breath. I will think about if the patient have a foreign body ingestion or not, if the patient is known case of asthma or inflammatory disease. I will think about mucus plug. I can see that there is density, increased density seen within the right hilar area. I want to zoom this image, please, to further assessment.
Okay, you are thinking good. It's okay, no mass here. Okay, so
No
you,
mass
this is the diagnosis of
right upper lobe collapse.
the second case for you. This is more classic.
Yes.
This is more classic. The last case, we didn't see the classic displaced loop. But here,
Yes.
try to explain well and
Yes.
mention all signs.
Okay. I have been presented with a frontal chest radiograph for an adult patient. I can see that there is collapse of the right upper lung zone with the evidence of golden reverse S side. Also, there is a crowding of the right upper ribs. Also, there is decrease in the right lung volume. I can see that there is crowding also seen in the right hilum, raising the possibility of the right hilar mass lesion. In my routine practice, I will ask for chest and abdomen and pelvis CT scan with IV contrast to rule out any endobronchial mass lesion or carcinoma.
Okay, very good. Except you said golden S. Golden S, okay? Can you comment on this one?
Yes.
Then we will compare.
Yes. This is a classic golden S sign.
Yes, this is classic golden S sign, whereas there is convexity here and separate. You see, separate from the hilum. But here, this is a hilum, okay, and no convexity here. This is the hilum, and this is classic right upper lobe collapse. But here is the golden S, okay.
Yes.
You have to discriminate between both entities. Here is just a consolidation in the upper loop. The loop is not, or the fissure, I'm sorry, is not displaced. So here, displaced in case of collapse, not displaced in case of consolidation. And here, associated with a golden S. Again, golden S means a higher mass obstructing the upper loop bronchus. You will see the shifted fissure, and you will see the border of the mass against each other. Okay. Another case for another candidate. Thank you, ya boss.
Thank you.
Hello, Assalamu alaikum.
Alaikum salam. How are you?
I'm good, thank you. So I'm presented with a frontal chest radiograph of an adult patient, and most striking abnormality is volume loss of the right hemithorax with shift of the trachea to the right side, indicative of the volume loss. I can see that there is opacity projecting over the right hemithorax with elevation of the fissure and forming convexity and concave border inferiorly,
Yes.
the typical golden S sign, but I can see maybe a reverse S, and
Okay.
I can see that there is opacity seen, more dense opacity seen over the hilum. There is no pleural effusion. Evaluation of the other lung demonstrate no abnormality. Looking at the bone grossly normal. So an adult patient with right upper lobe collapse.
Looking at the bones, normal bones, huh?
No, you
I am very sad now. Okay.
Okay, you're a nice examiner. So I can see that there is at the right acromioclavicular joint, the distal end of the clavicle, there is destruction and widening of the joint space. I don't appreciate similar on the left. So, and I can see there is a fractured right lower rib laterally. Not sure if this fracture is pathologic fracture, if there is any
Yes.
lesion, you cannot appreciate.
And also, if you compare soft tissue here overlying this area, this is a tense rib, it is not continuous. You see, there is
Okay.
lack of the rib here, okay? And also associated with some soft tissue thickness. So correlating, summarize the case, okay?
So to summarize, an adult patient with right upper lobe collapse and rib fracture, pathological right lip fracture, and also lesion on the lateral aspect of the clavicle. These findings concerning for malignant process, which could be a metastasis, could be a primary bronchial cancer with metastasis to the bone, or metastasis to the bone and endobronchial metastasis from another primary. So we'll compare with the previous if available. And if not, we'll proceed with chest CT scan and refer the patient for next pulmonary MDT for further discussion.
Very good, yes. So we have here multiple appearance regarding the left upper lobe. The fissure may be shifted smoothly, or the fissure may show a golden S sign, or the fissure may be not shifted at all in case of consolidation, or this case, I think brought by Dr. Noha, it's bulging to the opposite side, which means the whole fissure is bulging to the opposite side. Are you with me, same candidate?
Yeah, I'm with you. So bulging, I thought it is due to pneumonia, but that will be to the other, like bulging of a fissure with Klebsiella and...
Yes, Klebsiella and other organisms, as discussed,
Yeah.
I think, in the last time. Very good, yeah, boss. Okay, the last case, no, another candidate. Okay, thank you.
It's me, Doctor. Can I?
Okay, boss.
Okay. So I'm presented with a frontal chest radiograph for an adult patient. I can see that there is veil-like opacity seen at the left hemithorax with signs of loss of lung volume, elevated left hemidiaphragm, and elevated also the left hilum. This is highly suggestive of left upper lung lobe collapse.
Okay, any differential diagnosis if you know that this case is post-surgical?
Yeah, post-surgery, it's mucus plugging, the first differential diagnosis for this. I would compare it with the preoperative chest X-ray to confirm
Okay.
that.
Okay.
But also, I can see. Wait,
You
is
can
there
see now.
is there a left apical cap here? No.
Okay. Okay. But what's
Yeah.
here? What's here?
Surgical eclipse, yeah. Okay,
Surgical
surgery.
clips.
So
And
surgery.
I
Yes.
didn't say pulmonary surgery. Sorry. Okay.
Yes. Yes.
But
Okay, I
you
should
see
know it.
here, there is widening.
Yes,
In case
widening,
of
not
yes,
not approximation. It's the
not
opposite. I see it and I ignore it. Yes. Yes. Okay.
in
Yes.
case of left upper lobe collapse, we expect to see crowding. But widening,
yes.
why widening?
Mm,
Because maybe element of rib resection in this area,
yes.
together with
Okay.
these surgical clips at the hilum, may be related to lobectomy. Okay,
Yes.
previous lobectomy, not total pneumonectomy, okay, but just lobectomy. So
Okay.
in case of lobectomy, it's a differential diagnosis of lobar collapse. This may be just thickening. If no surgical history and you see this part only, this is suggestive of pancreas tumor, but in another setting, not in this setting. Okay.
Yes.
Good, yeah, boss. I'll.
Thank you.
Okay. Just wait
Okay.
for me. Wait.
Okay.
I think we finished the third. Okay. Two cases.
I knew.
This is
Okay. Pneumoperitoneum. Yes. Okay. Yes.
Mashallah. Okay. Just this is a welcoming. Okay. Pneumothorax, pneumodiastine, pneumoperitoneum, and in children,
Yes.
ribs.
Rib fracture for
In children,
non-accidental injuries.
don't expect to see pneumoperitoneum like this.
Mhm.
It will have a different pattern. Okay. Just this case for you. This is the next set of cases. What's the abnormality here?
I can see that there is diffuse coarse reticular opacities in both lungs, diffusely involving both lungs, symmetrically bilaterally.
Lung volume.
Yeah, it is
reticular.
decreased.
Okay.
Yeah, decreased lung volume.
Okay. And
the costophrenic angles are obliterated more at the left side. Okay.
in case of reticulations, we comment on lung volume, we comment on heart border and diaphragm regarding shaggy pattern. Okay. It's not very well defined because of these reticulations. So mild reduced both lung volume, symmetrical reticulations, the loss of lung volume more at the basis with shaggy outline. I'm thinking in
fibrosis.
Okay, which may be related to
I don't know.
no problem. This is the next candidate. Okay. Thank you, Yabos. Thank you.
Okay, thank you.
The next candidate.
Yes.
Okay. Another case, chronic symptoms, chronic chest symptoms.
Okay, I am presented with a frontal chest radiograph of adult patient. showing bilateral symmetrical coarse reticular and reticular nodular shadows. It seemed to be increasing apical to basal gradient.
Good.
There is a shaggy border seen along the left cardiac and right cardiac borders, suggestive of fibrotic lung changes with the lower lung predilection.
Good.
So I am start to search for the causes of lower lung interstitial diseases such as connective tissue disease. So I'm start looking at the shoulders for any changes such as rheumatoid changes.
Good.
And looking at the esophagus at the right paratracheal line. So if there is esophageal distension suggestive of scleroderma. Also, we can ask the patient if there's a history of aspiration pneumonia has been before, or any drug toxicity if the patient is any drug which causes lower lung interstitial lung disease. So then
mention one drug.
methotrexate or amiodarone.
Okay, so no cardiomegaly. Good. No cardiac pacemaker to suggest this etiology. Very good. Okay, and also no plaques. No calcified pleural plaques. Very good. Very good, yeah, boss. Okay, continue with the CT scan.
Okay, and there's bilateral honeycombing and directional bronchiectasis and subpleural fibrotic bands with the epicobasal predominance. And there's no, also there is volume loss. So it is a sure sign of an interstitial lung disease with a lower zone predilection. So also I have to keep the, I'm looking for the previous causes. The esophagus shows normal outline.
Yes.
And I'm looking for rheumatoid evidence in the shoulder or dense liver, no dense liver.
Good. No dense liver, no pleural plaques. Very good, very good. So the final diagnosis will be?
Interstitial pulmonary fibrosis, fusional interstitial pneumonia, and I would refer the information for the referring physician for lung entity, interstitial lung entity.
Okay, Abbas. Okay. The same diagnosis. These two cases has the same diagnosis. It's a reticular pattern associated with volume loss. Reticular pattern, we have to comment if it is unilateral or bilateral. If it is normal preserved lung volume or reduced lung volume. If it's predominantly middle and upper zonal or lower zonal. Most of these cases will be lower zonal. In case of lower zonal reticulations with reduced lung volume and irregular shaggy pattern, no hyperdensity of the liver and no cardiomegaly, no open heart, that's seen with amiodarone. No calcific plaques, that's seen with asbestosis. No dilated esophagus, that's seen with scleroderma. And the pattern here is classic. Predominant lower lobar bronchiectasis, that's classic for UIP or interstitial pulmonary fibrosis. I'll put if you see a similar pattern, but this case, the next candidate. Thank you, Boss.
Thank you, Dr. Ismail.
Welcome. Reticular pattern on chest X-ray and this pattern on CT. Who will describe?
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. How are you, يا boss?
أهلا وسهلا حضرتك. I will continue in the same chest X-ray which was reviewed.
Yes, okay. Chest X-ray was show a reticular pattern, and this is the CT.
Okay.
I'm sorry to interrupt. So we have candidate 11, we have candidate 12, and candidate 13. You can be candidate 14. So I will change you to that, but we will keep the order. So candidate 11, are you there?
Sorry for that.
I'm here.
Sorry.
No problem. No problem. Okay, candidate 11.
Yes, can you hear me?
Yes, yeah, boss, I hear you. Okay, you can describe the next two cases. This case first.
Okay, so this is a chest CT. I can see some ground glass opacities mainly subpleural in location on both sides with a lower lobe predominance. I can see some cystic changes also in the basal segments.
Okay.
So the appearance of ground glass opacities with cystic changes gives me
As well as some reticular thickening.
yes,
Okay.
thickening of
Thickening
interlobular
of interlobar incision. Okay.
so this is possibly a case of LCH.
No abbreviations in the exam. Okay.
Langerhans cell histiocytosis. Yes.
Langerhans cell histiocytosis.
I don't see
Do you
nodules,
see,
however.
do you see the cystic pattern is the predominant or the ground glass is the predominant?
The ground glass is predominant.
Yes.
So
If the
it could
cystic
be
pattern is predominant, you can go cystic lung disease. Okay?
yes.
But here it is not. It's reticulations and minute cyst, but on background of ground glass.
Okay. Could it be lymphangiomatosis?
Again, it is not cystic pattern.
Okay.
What is this pattern? If reticulation with ground
Yes.
glass equals to
Non-specific?
yes, yeah, boss. Yes. In such case, you have to comment on
The esophagus.
why.
It could be dilated in cases of scleroderma.
Yes, connective tissue disorder is one of the known causes of non-specific interstitial pneumonia with scleroderma seen as dilated esophagus. The next case has dilated esophagus, okay, with some ground glass pattern, especially basal, especially pleural, with immediate sparing of subpleural area. You see this red or hypodense line, the immediate 5 millimeter, okay, is spared. It's also a non-specific interstitial pneumonia, but here, with the presence of dilated esophagus, I will put the possibility of connective tissue disease, especially scleroderma, as the cause. I'll give you this case, but we will revise again. If we see reticulations with reduced lung volume and shaggy pattern, this is most likely reticular or interstitial lung disease. If acute, I'll go with cardiac. If chronic, maybe related to fibrosis. Where is the affection? Where is the affection? Okay. The affection here is predominantly basal. It's lower. If no apparent cause, it will be UIB. If ground glass pattern, okay, non-specific, interstitial. Dilated esophagus, scleroderma. Okay, what about this case? You can start. Chronic symptoms.
Frontal chest radiograph for an adult patient complaining of chronic chest symptoms. I can see there are reticular opacities occupying both lower zones.
Good.
Um,
Shaggy border or regular border of the heart and the diaphragm.
Yes, the outlines of the heart and diaphragm are irregular and shaggy. I suspect there is opacification of the right upper zone. Could be related
This is
to
maybe
upper.
related to just malrotation. Okay. Any specific history you want to ask about?
So I would like to ask for occupational exposure.
Okay. You see this pattern, this triangular opacity?
Yes.
What could
this
be?
leaf-like
Yes.
opacities makes me think of pleural plaques, which could be, yes, related to asbestos exposure.
Yes.
This is, yeah, I can
Okay,
see
just
calcified pleural
yes,
plaques.
describe it as a whole before we finish.
So these I can see calcified pleural plaques occupying the parietal pleura, mainly on the left side. There are honeycombing pattern and increased reticular or thickened interlobular septi.
Okay. And traction.
There are also traction bronchiectasis.
Yes.
Yeah.
If you want to speak about fibrotic reaction, mention all criteria. The interlobular interstitial thickening with some irregularity, the honey combing, the traction bronchiectasis, the distribution. The distribution is very important to put the differential diagnosis. It's predominantly basal and subpleural with relative sparing of the lung bases. Okay. Now you put the differential according to these calcific plaques. It's
asbestosis.
If no plaques.
If no plaques, it's usual interstitial pneumonia.
Or other list of lower lung fibrosis. Okay. So last.
Yeah.
Okay, boss. Well, very well. Very well. Very well. Okay. Welcome. Another candidate. We are close to, I think.
Yes, doctor.
Okay.
Okay. Yeah, I'm provided with a frontal chest radiograph. I can see there is ill-defined opacity in the left lung lower lobe, obscuring the left heart border and the left, mainly left heart border. And in the right chest, I can see the opacity along the lateral margin. It is somewhat irregular, so it could be a pleural thickening. And bones are unremarkable. In summary, due to the celerity of left heart border, it could be lingular consolidation or collapse.
Okay, just alveolar opacities. Okay, and also we have some similarity on the opposite side. What if I told you this is a cardiac patient?
Okay, so
we will go down, go down, go down. Do you see anything here?
No, no.
The density
okay,
of the liver.
sorry. Yeah, see, it's high in comparison to the spleen.
Okay, this is granuloma, you can ignore. Okay. High
Yeah,
density of the liver with this calcific, calcification, old age, cardiac patient. And what's in the lung window?
And on the lung window, there is a subpleural reticulation and representing a picture of NSIP, non-specific interstitial pneumonia. And so these findings collectively represent the side effects of a drug like amiodarone.
Very good, yeah, boss. Very good. Amiodarone is a cardiac, one of the cardiac treatment that it may cause toxicity to the lung in the form of interstitial lung thickening, and to the liver also in the form of hyperdensity. If we stop the drug with some steroid therapy, I think, okay, everything can return in the early phase to normal, but later may be irreversible. So if we find a cardiac patient, a sternotomy suture, cardiomegaly, maybe pulmonary edema, maybe in the phase of pulmonary edema also, cardiac pacemaker, whatever this, which guide us toward cardiac patient, and we see hyperdense liver with some pulmonary reticulations, we will go through amiodarone lung toxicity, one of the causes of basal or lower lobar lung fibrosis. The last case for you, yeah, boss.
Yeah.
Okay. Welcoming message. Okay.
So I'm provided with a frontal chest X-ray of a premature infant, premature neonate.
Emergency or no? Just emergency or no?
Yes.
Of course, there is emergency.
Yes, I can see air. It's like a pneumoperitoneum. I can see air under the diaphragm and in the center also.
Yes.
Uh,
Here, my friends, you see the abdominal wall is opaque. The liver should be the same opacity as abdominal wall. If any lucency here, it means massive pneumoperitoneum. If I don't know this information, I will comment on the chest and the lines and the tubes and fail. So remember, pneumoperitoneum in children is very tricky. Maybe at the edge of the film in chest X-ray of infant or neonate. Inshallah, I will repeat these cases with pediatric, okay? Just here for fun. Thank you, ya boss. Thank you.
yeah, okay.
Okay, the next candidate.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. You are number 12, ya boss, or 13?
No, I'm candidate 13.
Okay, okay. Chronic symptoms in old patient.
Okay, so I've been provided chest X-ray frontal projection of an old patient who have chronic cough. So in this case, I can see their bilateral reticular nodular opacities, which are more reticular in pattern with loss of lung volume bilaterally. Here I can see that there is inhomogeneous opacity which is occupying the left upper zone with some cystic changes in it.
No definite cystic change, maybe just the bronchi. But as you said,
Okay.
reticular and nodular. And the
Nodular.
nodules are
Small.
small and
Micronodule.
yes, and dense.
Yeah, and
Slightly
so,
dense. Okay.
yeah.
With here significant opacification and uplifting of the hyla. In old age, what you are thinking and any specific history?
So this could be due to any viral, previous viral
You mean
pneumonia,
the varicella pneumonia.
varicella
Okay.
pneumonia.
Good differential in absence of these apical opacities.
So this could be due to miliary nodular shadowing.
Okay, in immune compromised, I'm telling this is immune competent.
Okay, so
Let's
the
go
other
to CT. CT, okay. It's
Okay.
good thinking, by the way. You have good thinking.
Thank you.
Okay.
So here I can see that there are bilateral opacities with calcification and pleural thickening.
Good.
And
also calcific.
Yeah, calcific lymphadenopathy.
Good.
Mediastinal and hilar lymphadenopathy. So the differential in this case most probably could be due to rheumatoid arthritis.
No, I am very sad of you. Okay.
Oh.
calcified nodules, calcified lymph nodes, and calcified lung nodules with these apical lung masses.
So silicosis and
yes, welcome. Okay.
Yeah.
No one answer in the Dr. Dua, I'm angry with you. No one answers. Okay, back again to the chest radiograph. It's
Okay.
bilateral apical fibrotic masses. Okay, obscuring
Right.
most of the lung apex. Alone may be related to tuberculosis. Yes, yes,
Right.
accepted. May be related to silicosis. Yes, maybe one of them scar carcinoma. Okay, but correlate with these lung nodules. Lung nodules will guide us towards silicosis, especially with this high density, less likely tuberculosis. Go for CT scan. Go diabos. So this is one of the upper lung fibrosis. Okay, this is your first case.
Yes.
Okay, go for this one.
So I've been provided with XHS frontal projection of skin of an adult patient. Here I can see that there are micronodular opacities in both lung fields with fibrosis and cystic changes in the both lung apices. So my first differential in this case is pulmonary tuberculosis.
Okay,
The
any
other
nodularity?
differential, yeah, so micronodularity
Yes.
could be due to again the differentials are silicosis, talcosis, and
Okay, which one you will will be the first diagnosis in such case?
So tuberculosis, my
Yes,
first
yes,
reference.
because of apical cavitations. Apical
Yeah.
cavitations with this low density nodules, this case is emergency or no? Yes,
I could not see
yes.
any
Yeah.
pneumothorax or
No. I mean, the emergency here is not due to pneumothorax or pneumodiastema, because these miliary nodules, the patient is infectious,
Yes. Okay, so
highly infectious. What is the management of TB? Mentioned
So,
very rapid, okay?
okay, so we will ask for isolation of the patient, and
Yes.
the patient contact should be scrutinized and isolated if found positive for tuberculosis.
Okay, okay. And of course, CT scan urgently looking for this miliary pattern or teary impact. This is another case of apical cavitations also and some fibrosis. So apical reticulations, loss of lung volume at the upper lung lobes may be related to TB. Look for cavitations, look for any nodularity, especially on CT. You may find this type of nodules,
Yes.
which are,
Endobronchial.
yes, this is
Endobronchial spread.
considered, yes, 3 embed around bronchial spread. This is considered an emergency case. This patient is highly infectious or contagious to the surrounding. Okay.
Okay.
Very good, yeah, boss. Thank you. Thank you.
Thank you.
Welcome. Number 14.
Assalamu alaikum.
Alaikum
I'm
salam wa
presented with
rahmatullah.
I'm presented with frontal chest radiograph of an skeletally mature adult patient showing bilateral diffuse lung parenchymal filling opacities with coarse reticular pattern.
Good.
Merely of upper lobar, bilateral upper lobar predominance with micronodular infiltrates.
Good. And also?
I think there is zooming. Yes. There is bilateral, mildly elevated post-hilum, denoting suggestive of fibrotic changes. And also there is stenting of diaphragm with reticulation.
Okay, a part of the reduction of lung volume. Okay, any differential?
For this patient with bilateral reticular pattern with almost decreased lung volume, mainly upper lobar predominant, I will think about some sarcoidosis, tuberculosis, but the mediastinum and yes. Okay, I'm presented with axial CT chest showing diffuse medial reticulonodular pattern with coarse interstitial thickening, mainly middle and upper lung zones, with early fibrotic changes. I would like to revise the soft tissue window, to check for any hilar or mediastinal lymphadenopathies. Also, there is pattern of nodular.
Okay.
Yeah.
Yes, and the pattern of nodule here?
I will say yes. Here is nodular interlobar and interlobar septal thickening, distorting the lung parenchyma. I would like to, with lymphatic and bronchosvascular thickening.
Yes, this is a buzzword here. Bronchosvascular.
I will revise the patient history about the symptom and any other association. Maybe could be sarcoidosis, could be lymphangitis carcinomatosis. I will search for the rest of the images for any metastatic deposits in any elsewhere.
Okay, the first most common diagnosis for this pattern with this hilar engorgement, yes, is sarcoidosis.
Yes, sarcoidosis.
Any specific lab test?
Yes, sarcoid, the serological test for this. I don't remember this.
The patient has ACE.
Angiotensin and angiotensin converting enzyme.
Okay,
sorry.
Yes, no problem. It's markedly elevated in this case. Okay, again, one of the causes of upper lung fibrotic reaction is sarcoidosis. Look for hilar engorgement, hilar enlargement, lymphadenopathy, also eggshell calcification, and what types of nodules along the vessels, along the fissures. tiny nodules along the fissures, along the vessels that form a conglomerate masses at higher level. If at upper lung level, then silicose. Good يا boss. Another case with the same diagnosis, but here
Dr.
prominent.
Ismail,
Yes, yes,
Dr.
Yeah,
Ismail,
prominent.
yes,
Dr.
yes.
Ismail, that case we can put progressive massive fibrosis as a differential.
Yes, if these masses are upper lobar. If the same pattern here, nodular, and these masses upper lobar, we may put the differential of progressive massive fibrosis on top of silicosis. As silicosis is the second cause of peribronchovascular nodules, but sarcoidosis much more common in this pattern. Okay.
Can I put the lymphangitis carcinomatosis, Dr. Ismail?
On the tail of this list, okay, if there is evidence or something that guide us toward malignancy, okay. For example, if mastectomy in remember my friends, any chest x-ray, any chest CT, the first thing, rapid look on the breast shadows. It will change everything. If asymmetrical breast shadow, and mostly these cases will not come obvious. It may be presented in lung window, maybe implant, okay, surgical clips. It will change your diagnosis, okay. Okay, let's go now. The patient, the next candidate, please.
Yeah.
Okay.
Oh, yes. Okay.
Okay. This patient has chronic back pain and chronic chest symptoms.
I'm presented with frontal chest radiograph showing bilateral reticular lung pattern, mainly central parahilar. There is also right middle lung zones, lucent lesion, lucent areas, like a cavitary lesion. Yeah, there is left lower lung zone wedge-shaped opacities.
You can collectively see or say this is fibrotic reactions.
Fibrotic, yes, bilateral diffuse lung fibrotic changes with right
Yes.
middle lung zone cavitary lesion.
The clue here will be reduced lung volume. Okay, on both sides.
Both,
yes, diaphragm and the hilar shadows, multiple reticulations. Okay, the predominant affection middle and upper. As you see here, no significant affection in the lung base, just elevated. Middle and upper may be related to sarcoid, may be related to TB, and. If I told you the patient has back pain, or if yes, yes,
because back pain, I would like to check the sign of ankylosing spondylitis.
Excellent. This is not typical cases of syndesmophyte, okay? But ankylosing spondylitis is one of the causes of middle and upper lung fibrosis. Again, it is not lower. Reticulation, reduce the lung volume, relatively sparing of the lung bases, okay? One of the causes is ankylosing spondylitis. And another cause is, what is this? Easy case. You also.
BCB, upper lobar fibrosis. It could be tuberculosis.
Young patient, chronic chest symptoms. Yes.
LCH, Langerhans histiocytosis.
I don't know this pattern. I don't know. I will not help this time. Okay. You see this? This is a clue, most likely.
Yes. Sorry. This is.
This is a clue. Okay.
This is a bump. Lymphangitis carcinomatosis.
No. The finding here, bilateral scattered opacities. Okay. Patchy and linear. Some of these opacities, okay, surround dilated bronchi, and some linear bronchi, tram-like. So it's a bronchiectasis. Some have filled with air, some filled with mucus.
Cystic
In this,
fibrosis.
yes, in this relatively young patient with Bortacas or
Bortacas.
Vermacas or
For the
tunneled central venous line, yes, you think
for
in
enzyme
cystic.
replacement.
Yes. Okay.
Yes.
The last candidate, I think, it's for yes, for long-term antibiotics. For long-term antibiotics. I think I don't remember if this case brought by Dr. Noha or no. The last candidate. No candidate, I will answer.
It looks like, yeah, looks
Okay.
like we finished the 13, so maybe candidate 1 can start again. Candidate 2. Okay,
okay.
candidate 3.
I think you are candidate 3, okay?
Yeah, I'm candidate 3.
Oh, you are okay, yeah, boss. What's abnormality here?
The right hemithorax volume is decreased. I can see some metallic density is projected in the right lower hemithorax.
Yes.
And so that suggests some previous surgeries.
Good.
And the mediastinum, it is appearing relatively dense.
Okay.
And,
very good. And lung volumes?
Yeah, lung volume on the right side, it is decreased.
Good. This density overlying the mediastinum has very sharp lateral border, non-anatomical lateral border associated with some fibrosis. With the patient has previous surgery, any suspicion? And has a line maybe for chemo or I don't know. Hello?
I'm not sure.
Okay, no problem. I'll show you the CT. Okay.
Okay. Yeah, in the CT, I can see there is evidence of pneumomediastinum and
maybe not pneumomediastinum, maybe traction bronchiectasis.
Yeah,
very sharp line, very sharp line. Okay, with the mediastinum, this is classic for previous radiation. It's called radiation pneumonitis. Okay, one of the upper lung causes of fibrosis. It has a very well-defined lateral margin merged with the mediastinum. Okay, and evidence of previous surgery. Like you said, we have surgical clips. You see here, very well-defined margin. It's a classic pattern. No problem. Before I study FRCR, I didn't know about it. Okay, it's okay, Abbas. We will revise, inshallah, the all cases, but this case for you.
Yeah.
Emergency.
This is the chest radiograph of a pediatric patient where I can see the thymus appearing elevated, like a sale sign, which suggests a pneumomediastinum, which is an emergency.
Excellent. No other emergency? I am very sad. Pneumomediastinum only? Very well-defined cardiac border.
Yeah,
you see,
pneumopericardium.
Yes, not pneumopericardium, not pneumopericardium. And this?
Deep sulcus.
Yes, deep sulcus sign. Markedly defined the cardiac border. It's pneumothorax with pneumomediastinum. Okay, I think we finished. This is a case of interstitial pulmonary edema, one of the common causes of reticular opacities, but the patient has acute symptoms. Okay, we will not discuss these cases, I think, discussed by Dr. Noha. When we find reticular opacities on just one side. I will revise now in just a couple of minutes the two topics of this lecture. Lobar collapse, we may have many types of lobar collapse. Just to revise, left upper loop will be veiling, reduced lung volume, left sickle sign, like in this case, it's a classic. Reduced left lung volume, elevation of hemidiaphragm, elevation of or traction upon the left hilum, plus or minus masses, left and left sickle sign. Okay. Another case. This is the explanation of left sickle sign, because here in the upper segments of left lower loop go intersect between the collapsed upper loop and the thoracic aorta. Okay, the second one is left lower loop, triangular opacity, retrocardiac, loss of definition of left hemidiaphragm, and the hilar vessel, the interloopal vessel, will not be seen on this side, like this case. Medial hemidiaphragm is lost, retrocardiac opacity, hilar vessels is not seen here, and of course the clue, reduced left lung volume. Okay, another one on the right side, similar pattern, retrocardiac, triangular opacity, loss of definition of the hemidiaphragm with signs of volume loss, reduced right lung volume, ipsilateral mediastinal shift, and rib crowding. One of the difficult cases and may appear as a normal radiograph is a middle loop collapse. The middle loop collapse will be so clear on lateral, but on frontal view, just ill definition of the right cardiac border. It carries one or three diagnoses: the middle loop collapse, consolidation, and pectus excavatum. The last one is the upper loop collapse, usually linear elevation of the upper of the transverse fissure. If this fissure has S shape, think of S golden sign of S. Hilar mass. If bulging fissure, think of Klebsiella. About reticular pattern, this is the second topic today. Reduced lung volumes with bilateral lung reticulations, shaggy borders. Okay, it's interstitial lung disease. Where is the predominant affection? If it is lower looper, we may have many differential diagnoses. Like if we have, for example, calcified pleural plaques, history of asbestosis, you have to ask about occupational history. Asbestosis is one of the causes. If cardiomegaly, cardiac device, sternotomy, and hyperdense liver, amiodarone toxicity. If you have dilated esophagus with ground glass, it's scleroderma. If ground glass pattern, no significant honeycombing, this is non-specific interstitial pneumonitis. And if no apparent cause with extensive honeycombing, this is the interstitial pulmonary fibrosis or UIP pattern. If upper lung predominance, think of TB and cystic fibrosis will be on the top of the list. Okay, bilateral cavitations, maybe TB. Look for unilateral lymphadenopathy or miliary nodules. If bilateral apical opacification, maybe progressive massive fibrosis. Look for calcified nodes in CT scan or calcified nodules. If predominant affection of hilar enlargement and peribronchovascular nodules, this is sarcoidosis. Revise the types, of course, or stages. If associated with neck pain or back pain, or the examiner showed you another classic radiograph of bamboo spine, this will be ankylosing spondylitis, and this is, of course, cystic fibrosis. Last to remember is the non-anatomical, very well-defined mediastinal opacity with loss of lung volume. This is radiation pneumonitis. Reticulation on one side only, maybe interstitial lung disease and have transplantation, maybe interstitial pulmonary edema, the patient lying on one side in most of the cases, maybe lymphangitis carcinomatosis. Thank you and sorry for a long time. Okay, and see you inshallah next session at next Saturday.